Good day, this is Thaduri Revant Reddy, and my topic for the biochemistry is use of lab test for MI diagnosis, which is myocardial infarction. And let's discuss a small information about the myocardial infarction, which is also known as the heart attack. A heart attack happens when one or more areas of the heart muscles don't get enough oxygen. This happens when blood flows through to the heart muscle is blocked. A blockage of blood flow to the heart muscle. A heart attack is a medical emergency. A heart attack usually occurs when a blood clot blocks blood flow to the heart. Without blood, tissue loses oxygen and dies. And symptoms include tightness or pain in chest, neck, back, or arms, as well as fatigue, lightheadedness, abnormal heartbeat, and anxiety. Women are more likely to prone to have typical symptoms than men. Treatment ranges from lifestyle changes and cardiac rehabilitation to medication, stents, and bypass surgeries. And hospital admission should not be deferred pending investigations. Laboratory investigations complement clinical and electrocardiograph assessment, especially if the latter is normal or shows a non-specific abnormality or left bundle branch block. Laboratory tests for myocardial infarction vary in onset and duration of abnormality, and results may be unavailable or normal when a decision on thrombolytic therapy must be made. And now going to the laboratory tests and their uses. First, cardiac troponin I or troponin T, which are both very sensitive and specific and are the recommended laboratory tests for the diagnosis of MI. Serial testing is recommended in order to confirm or exclude a rise or fall in troponin concentration. Troponin is the recommended test for myocardial necrosis. However, there is a marked variance in diagnostic thresholds among different assays. Care should be taken to ensure decisions are made using method-specific thresholds. The test becomes abnormal within 2 to 24 hours of commencement of pain, depending on sensitivity of the troponin assay, and remains abnormal for 7 to 10 days. The diagnosis of MI is based on a rise or fall of troponin, which at least one value above the 99th percentile for the population in setting of clinical or ECG findings consistent with an MI. Additional tests can be used, which are creatinine, serum urea, electrolytes, glucose, and complete blood count. If shock is present, we should check for the blood arterial gas. If lipid studies are required, blood should be collected within 24 hours or the study should be deferred for 8 weeks as cholesterol levels decrease after myocardial infarction. Three major non-invasive tools are the ECG, cardiac biomarkers, and stress testing. In equivocal cases, coronary computed tomographic angiography may be useful to improve the accuracy and speed of the diagnostic evaluation. The goals or the uses of the laboratory test for the myocardial infarction diagnosis are recognize or exclude myocardial infarction using cardiac biomarkers, preferably CTN, detect rest ischemia, usually serial or continuous ECGs should be used, detect significant coronary obstruction at rest with CCTA and or myocardial ischemia using stress testing. If new elevations in cardiac markers or ST T wave changes on the ECG are noted, the patient should be admitted to the hospital. Patients who remain pain-free with negative markers may proceed to stress testing to determine the presence of the ischemia or CCTA to detect coronary luminal obstruction. And now the alternative cardiac markers include the MB isoform of the creatinine kinase, which is known as CK-MB, is the less sensitive alternative, and we can also check for the elevated levels of any of these markers, which distinguish patients with NSTMI from those with UA. There is a characteristic temporal rise and fall, peaking 12 to 24 hours post onset of symptoms of the plasma concentration of these markers, and a direct relationship between the degree of elevation and mortality. CKMB with CKMB by CK ratio, which is sensitive and specific but inferior to troponin, and to be used only if troponin is unavailable. It may be of value to diagnose reinfarction. Myoglobin can also be used, which is sensitive but not specific. Peaks within 4 hours of the onset of pain, not recommended due to lack of specificity for cardiac damage. Next obsolete test will be creatinine kinase test, which is sensitive but not cardiac specific, only recommended in conjunction with CKMB. Aspartate aminotransferase, lactate dehydrogenase, which has very low specificity and generally not recommended. Next, lactate dehydrogenase isoenzyme, which are reasonably sensitive and specific, remains abnormal for up to 7 days after onset of pain and usually not recommended too. The group of cardiac enzymes like creatinine kinase, aspartate aminotransferase, and lactate dehydrogenase is unsatisfactory for the reliable diagnosis of myocardial infarction, so they usually are not recommended by the doctors. The above PPT which I showed is mostly taken from the Harrison's Principles of Internal Medicine and the other website provided. Thank you.